Okay, start.
Welcome to AETCM, the emergency medicine channel. Can we start?
Yeah, please.
A 75-year-old female, known case of CAD, hypertension, dyslipidemia, presented to ER with complaints of fever since 1 day, associated with cough with expectoration since 3 to 4 days. On initial 10-second assessment, patient conscious oriented, airway is patent, no pooling of secretions, breathing saturation was 98%, room air, respiratory rate was 22 per minute, normal vesicular breath sounds heard along with bilateral crepitations.
Okay.
Coming to circulation, BP was 130/90 millimeters of mercury, pulse rate 84 per minute. All peripheral pulsations equally felt bilaterally. Disability, GCS was 15/15, bilateral pupil equal and reacting to light. Coming to exposure, she was afebrile and GRBS was 137. Coming to history, a 75-year-old female, known case of CAD, hypertension, dyslipidemia, presented with complaints of fever with rigor since 1 day. It was associated with body pain, cough with expectoration, and post-tussive vomiting. No history of any dyspnea, loose stools, altered mental status, hemoptysis. On examination, patient was conscious oriented, obeying commands, no pallor, ictercyanosis, clubbing, lymphadenopathy or edema. Respiratory system, bilateral scattered craps were heard and other systems were within normal limit.
Okay.
We had taken a VBG.
Okay. We'll just wait. From the history, an elderly gentle woman who has come to the ED with short history of fever. Very short history of fever, cough and breathlessness. Breathlessness is also there. No, mild breathlessness. Maybe you can tell. Cough and fever is the main complaint for her. So, since 1 day duration.
Cough since 3 to 4 days and fever since 1 day.
Cough since 3 to 4 days and fever since 1 day duration. Come to the ED. She's hemodynamically stable. Oxygenation wise okay. And she don't have any features of hypoxia. So she's not, the most important thing what you have to see is curve 65. When you're looking in terms of any pneumonia, she's not confused. There is no uremia. We have to see the labs. Then you have to look in for the respiratory rate and blood pressure, no hypotension. Then age more than 65. So that is one thing that has become positive. Then depending upon the other thing, you can decide whether that patient need to be admitted or not. So that is your curve 65 that you can use in here. So the next important thing, you have taken a short history that you don't find anything. You were telling a lot of negative history. So what are the significance of those negative history?
Any GI symptoms associated with fever, cough,
Okay.
atypical pneumonia.
Okay. So you want to look in terms of an atypical pneumonia, which we will be suspecting the most common one. Why we will be suspecting? Because she is coming from the community. And the most common things that you can get is a viral pneumonia. Viral pneumonia at any point of time you can get. So viral pneumonia or any other atypical organisms that can present with atypical symptoms of an respiratory tract infection. But she's having typical symptoms. She's having fever, cough and some productive expectoration, everything she's telling. But sometimes the patient will come with fever with altered sensorium, loose stools. Then you are evaluating, you are finding a pneumonia. So that group we will say it as a typical pneumonia. So she don't have any atypical symptom as such. She's having typical symptoms of an probably a respiratory tract infection. Now we need to say where exactly is the respiratory tract infection. Whether it is in the bronchus or whether it is in the lung parenchyma. That is only our difference. Whether it's an upper respiratory or a lower respiratory tract infection. So that is only difference that is going to make. Both this can have fever, cough and productive. Mostly when you say productive expectoration, lung parenchymal involvement will be there to some extent. And she is not tachypneic. And there is no tachypnea.
Yeah,
22. Maybe mildly tachypnea. You can say tachypnea is present, but hypoxia is not there. And you have taken an VBG. I want an ABG here. So this is a condition where you have to go for an ABG. But looking at the saturation, I don't even need any of the parameters. But ABG will help us to let you know one thing, whether I am now more concerned about PCO2. I'll be more concerned regarding PCO2. I can know if the PCO2 is somewhere like 45, that it is upper than normal. So she might be having a breathlessness for a longer time and maybe that respiratory rate would have come down and she might be going for an impending respiratory failure. That also is a possibility. You look in that way, her respiratory rate is like it was 40. She was tachypneic. Now her effort has come down and as a result, respiratory rate is only 22 now. So that is one possibility. But here we will take it the other way around. She is only having a respiratory rate of 22 because it's a short history. Suppose you had given me like 3 to 4 days of history and initially the patient was very sick. Now the respiratory rate has come down and still she is sick. The reason maybe she is going for an impending respiratory failure. Why I don't want PO2? Because already you are getting the saturation of 98. So saturation of 98, you are always sure that PO2 is above 60. So which is reasonable for any patient that is coming to the emergency room. So PCO2, if the PCO2 is like 35 or 30, so what does that mean? 35 or 30. You can make it as 35. Imagine the PCO2 is 35. How will you infer that PCO2? Tachypnea. She is going in more of a type 1 respiratory failure. So type 1 respiratory failure, even before your hypoxia starts settling in, the patient will be tachypneic as evident by PCO2 washout. So when PCO2 is built up, you will call it as type 2. When PCO2 washout is also there, we classically won't call it as type 1. But if the patient is not been attended during that time and she is going for further worsening of hypoxia, she will go for a type 1 hypoxia. So classically when we say type 1 respiratory failure, we will say hypoxia. And type 2 respiratory failure, we will say hypoxia with PCO2 buildup. So preferably an ABG would have been an ideal choice to look in for the PCO2 for this patient at this moment. Maybe later on she is hypoxic, definitely an ABG. But VBG won't give you much clue. And you can look for other acid-based disorders if you want to look in for any. So acid-based disorder, the pH is reasonable to get those things. Can you just tell the values?
pH was 7.423.
Okay.
PCO2 was 35.5. Potassium 3.6. Sodium 135. Lactates was 4.7.
Okay. So from here, let's see the pH first. 7.423. So 7.423, she is going into an alkalotic range. Even if it is in the normal, she is going for an alkalotic range. You look at you have taken a VBG and in a VBG, the PCO2 is 35. So what does that, how does that infer? There is washout. So definitely if you have taken an ABG, it would have been less than 35. So that is the one reason. She is going for an impending, going to happen a type 1 respiratory failure. Even in a VBG, the PCO2 is 35. And other thing that you said is lactate 4.7. So how will you attribute this increased lactate? She is having a normal blood pressure. Why there is an increased lactate for this patient?
Increased respiration.
Increased
Tachypnea
effort. So how does it increase the lactate?
It causes production of lactate due to anaerobic metabolism.
22 respiratory rate. 22 respiratory rate. That is when you see a dog that in the street you will have a respiratory rate of 22. It is not that high. So this lactate, we cannot just say it is due to tachypnea. 22 respiratory rate is not to that extent. So maybe you have to look for other reason why the lactate is elevated. So what are the other reason that you might say the lactate is elevated? What are the other reason? As you said, sepsis. You said regarding sepsis. So sepsis before a hypotension develop in, you can have, we have discussed this previously also, sepsis can have multiple reasons why there is an elevation in the lactate. Even if without hypotension, you can have an increase in lactate. That is a mitochondrial mechanism. Or else an elderly lady, whether she is taking any drugs that can increase the lactate level. Metformin, one of the most common one. Metformin, we can see an increased lactate. Then what are the other drugs that can increase lactate? Again, we have discussed last time. Most common drugs. See, whenever you see a lactate, you don't just say that it is because of the increased work of breathing. Don't just, you have to chase behind it. Why there is a lactate? Lactate will not increase just like that. It can be as a global reason of an infection, sepsis, or it can be due to the rigors that she had developed. That is one possibility. Just because of the respiratory rate, you cannot say that it is on the higher side. And the next important thing, nebulizations. Adrenaline is one nebulization. Adrenaline can increase can transiently increase the lactate, but not to an extent of 4.7. So when we say 4.7, normally you will take it as cutoff of less than 2. More than 2, you will call it as hyperlactemia. But more than 4 with acidosis, we will call it as lactic acidosis. So what will be the other reason? Any drugs. What are the other drugs? Commonly antiretroviral therapy drugs. That is the other agent that we have to look in for, that which can increase the lactate. Most commonly metformin. So whether she is a diabetic?
No.
Not a diabetic. And any drugs that can increase lactate, what all drugs that she is taking? or else whether the lactate clearance is getting delayed. So that is also one reason the lactate, the metabolism of her is very weak in case of a liver failure patient. So the lactate is getting taken time to get cleared. Maybe a renal failure, most commonly liver failure. So if any one of these things, sir, that lactate will be high. Or else she is going for there is a shock that has developed. But the body has compensated that and the blood pressure is maintaining. So that is another possibility. Whenever there is a tissue hypoxia, you can call it as shock. But the body's compensatory mechanism is acting in a way that she is not having hypotension. So what we'll call it as compensated shock. So that for you have to look for the CRT. You said CRT was how much? You didn't say about CRT.
Peripheral pulsations equally felt.
Peripheral pulsation will be equally felt. You have to look for the CRT. So that is the next thing. Or you have to look for other features of decreasing in neuron output, or any of these things are there. Maybe she's not been treated right now. She might be having a shock, and later on it can go into an hypotensive shock. So that is your compensatory mechanism fails and you can go for an decompensated shock or hypotensive shock. So when you say about the shock, that always doesn't mean that the patient is having hypotension. Shock can be there without hypotension also. But all hypotensive patient will be in shock. You understood the reason. So all hypotension, they will be in shock. But all shock patients may not have hypotension. So that will be the other reason why there is an increase in lactate. So we have to find out why. That question of why should always rise in our mind. Why the lactate? We should see and find out. Maybe after you hydrate the patient very well, you start her on antibiotics, later on the lactate clearance would have come back and the next lactate might be less than 2. So you have treated everything and it has come down. But again, you have to see the reason why the lactate was elevated initially. So what was the next ABG? Any values you have? Next lactate level? You don't have. So always whenever you see an increase in lactate, make it a practice after 2 hours of your treatment how the patient is responding to the lactate. So that is what we call as lactate clearance. So look at the lactate. Ideally, if there is a 50% of clearance, that is very good. If it was something like 4.7, it is now less than 2.5, it is very good. That is the ideal lactate clearance, but it is that level. It is okay, but it is increasing. Your target treatment is not going appropriately. So that is a marker. So whenever you see an elevated lactate, make it a practice of looking for the lactate clearance at least after 2 hours. But within the 2 hours, you should have done some interventions. Without doing an intervention, there is no point in checking the lactate. Interventions like fluid resuscitation. If you have stopped the reason why there is a lactate, you have given an antibiotic for your sepsis control. So all those things should have been done. But liver failure and all, we cannot do anything because that will take time to resolve, depending upon what is the type of liver failure, reason behind liver failure and all. But always make sure that you are checking another value. So a small investigation will give you a lot of information. Okay. Then
We had taken a point of care CBC CRP. WBC was 9.65 and CRP was 238.13.
9.65 neutrophil or lymphocyte predominant?
Neutrophil predominant 67.2.
67.2
Neutrophils
of 9.8. Lymphocytes?
24.5.
24.5. Okay. Usually what will be the percentage when in an acute bacterial infections and all? It will be above 80%. That's a usual response. But here there is mild neutrophils, 40 to 50 you can take it as normal. Maybe 67% neutrophils and rest it is little bit of monocyte lymphocyte predominance is also there. So maybe a viral infection, maybe a bacterial. It's not very clear evident. We cannot say it is 100% bacterial. It can be possibly a bacterial infection also. Any inflammation can cause a shift to left or shift to right. Okay, fine.
We had taken a chest X-ray showing a left lower zone haziness was there.
Left lower zone haziness. Left lower zone haziness. Okay.
And we had started on injection augmentin 1.2 gram and injection SC 500 mg.
Okay.
And patient was admitted and the blood culture sensitivity was showing a gram-positive cocci.
Blood sensitive gram-positive cocci. So my question here, we will start from the first. We had seen a patient, left lower zone consolidation. Infiltrates, the patient is going for an impending consolidation. Right side, it was completely normal. So we are saying that this patient is having a right lower zone, probably a bronchopneumonia. It's what you are, or lobar pneumonia or a bronchopneumonia. We are not very sure unless and until we are taking any air bronchograms was evident in the X-ray.
No, my hair.
So if air bronchogram was evident, you can say it as most probably a consolidation will be the feature. So you can call it as either bronchopneumonia or lobar pneumonia, but you are getting some infiltrates. Okay, now what are the reasons for a right lower zone infiltrate? In this case, we have to take it as pneumonia only. But what are the other reasons you can get infiltrate? I am telling this patient is having cardiac failure. I am saying clinically this patient is have some cardiac history is there, no, for this patient, CAD. And see, so in this point of time, you can look in for your ultrasound help. So that is one you can look in for. You can look for the B lines. There is bilateral B lines. It can be seen in pneumonia. It can be seen in pulmonary edema also. But you have to understand that what is our LV fraction, LV ejection fraction?
It's good LV.
Good LV. Okay. So suppose the most common things is that it can be a coexisting of both pulmonary edema, and on top of that there will be an LRTA. So here there was no history of progressive, but she had 3 days history of cough. When she had 3 days history of cough, I wanted to know more regarding any history of orthopnea, any history of PND, any history of pedal edema worsening. So maybe I can attribute this way also. She had mild cardiac failure, which was happening 4 days back, and on top of a wet lung, she developed a lower respiratory tract infection. So that can be a possibility. So seeing an infiltrate just doesn't mean that it's a pneumonia. So on top of a wet lung, it is very common to develop both. To develop a pulmonary edema as well as you can develop infections also. So that history, there was no clarity. So that history you should ask for. So 3-4 days back, what was happening? Maybe if you are getting a history, something had some nose block, and later on, then we are thinking more of an infection. But here, the patient never had any fever to start off with. The patient just started off with cough. 3 to 4 days of cough. Then slowly, she started developing fever. So whether it was an initially some amount of cardiac failure, on top of that, she has developed an LRTA. So that clarity we need to have. Okay, so how will you, at this point of time, how will you say whether it is a wet lung? One is ultrasound help you can take, but you cannot differentiate it within a pneumonia, because once you are seeing an infiltrate, we are just seeing on one side, maybe other side also will be there. Maybe you are taking a CT, you will get a better picture. But all pneumonia patients, that doesn't mean they need a CT. You can treat them with this thing, that is fine. But how will you differentiate? That is the point when you can use your BNP. This is one area where maybe you can use BNP, whether you can look in for other features, and you can get an echo also done, and you can see how the cardiac contractility is there. So even if you are saying good LV function is there, I'll be still concerned that this patient is having a heart failure. Why? The most common reason for this group of patients is diastolic dysfunction. So diastolic dysfunction, they usually will have good preserved LV fraction, but they will come with pulmonary edema to you. So that is diastolic dysfunction. So I wanted to see what is the echo report, what was the grade of diastolic dysfunction that this patient is having. You know the Sterling's curve. So what is happening? There is a subtle increase in the volume itself will decrease the contractility, and the patient can have subtle increase in the maybe the last 2-3 days. She has not passed urine very well, or she has taken excess amount of fluid. So those group of patients, this diastolic dysfunction will be sudden onset of worsening will be there. And what will happen if you just give one shot of Lasix and just put a brief period of NVV, they will suddenly improve also. So that part also we need to look in for. What is the diastolic dysfunction? That's what, even if you say LV is good, I'll be concerned to know what is the diastolic function. So diastolic dysfunction, the classical presentation will be this. So they will be quite normal. Maybe there is some decrease in urine output, or there is an other trigger like a chest infection. I said regarding a pulmonary edema causing an LRTA, but it can be vice versa also. An LRTA can worsen the diastolic dysfunction, and they can come with both together. So whenever this elderly lady, chronic hypertensive ladies, and already known CAD. So diastolic dysfunction most commonly is it's a part of your hypertension. So we are always concerned regarding LV, but always you have to look the other part, diastolic dysfunction. If there is a diastolic grade 2 diastolic dysfunction, then this lady is very prone to develop this both combination. Maybe you have to give some amount of diuretics also, she will improve. Okay. So that is the next common thing that you need to look in for. That you said, and regarding coming to the antibiotics that you have started. So you have started the patient on augmentin and azithromycin. So give me justification for starting augmentin and along with azithromycin. So I wanted to get the justification why you started. I'm not arguing it, but I need justification.
Elderly patient.
Okay.
With comorbidities.
Okay.
It's, according to IDSA guidelines, we will start a combination of.
We are in India. Infectious Disease of Society of America, that is, we are in India right now. So we should have our own guidelines. So that is fine.
Gram-positive started because patient coming from a community, so most common organism is gram-positive.
Okay. Most common organism, I will prefer to argue, you are thinking of a bacterial infection, gram-positive will be most common. So gram-positive, you need to start one. You can start azithromycin alone. Why you started augmented with azithromycin?
Azithromycin coverage.
Atypical. Azithromycin will cover gram-positive. It will cover atypical. Why you wanted augmentin? That is my question. Augmentin will not cover gram-negative. It can have some penetration, but again, augmentin is not a very ideal choice for a good gram-negative. Why you started, and reason behind augmentin with azithromycin? Someone else would have started. I am putting you in trouble. But you should give me some reasons. See, when you are having such patients, azithromycin is a good gram-positive, but the coverage as compared with augmentin with azithromycin is less. Even if we say it has got gram-positive coverage, the azithromycin will have atypical as well as gram-positive. As compared to augmentin, gram-positive coverage is weak. So when you think about meningitis, that is a classical example I can give you. So when we started treating meningitis, initially ceftriaxone with crystalline penicillin was the treatment option. Now slowly ceftriaxone with vancomycin it came up. Now meropenem with vancomycin, most commonly depending upon that is the treatment regimen options. So what is the reason behind these things? There was case report where the penicillin was getting resistance to gram-positive organism. So we don't want to take any chance. So that is why vancomycin has been added as the first line agent by replacing crystalline penicillin. So ceftriaxone with crystalline penicillin changed into ceftriaxone into vancomycin. Ceftriaxone basically we are giving, it also has gram-positive coverage, but ceftriaxone basically we are giving for gram-negative coverages. Okay. So ceftriaxone with vancomycin, that was the reason. Similarly, azithromycin is a gram-positive, but it is not a very potent gram-positive organism coverage. Azithromycin, the advantage why we start for LRTA is that it will cover almost the organisms, and it also has got this anti-inflammatory property. So that will help in this patient. So that is one thing. And augmentin generally covers your gram-positive, and it covers some gram-negative organism, and it also have got anaerobic coverage also. Anaerobic coverage in the sense, when you are suspecting an aspiration pneumonia, it is not an ideal agent. But when you wanted to give an anaerobic coverage also, augmentin is reasonable. But when you want to really treat an aspiration pneumonia, it is not a good choice. You want to go for clindamycin. But there is no point in starting clindamycin along with augmentin, because clindamycin is a potent gram-positive coverage. Whatever augmentin is doing, clindamycin will do, and additionally it will have coverage for your anaerobic organism also. So the justification can be to improve the gram-positive coverage, augmentin was added, or else you can say this way, augmentin was given for gram-positive and we added azithromycin for an atypical coverage. So this way you can say. I am asking you another question. One drug if you wanted to give, which have both these coverages. So what are the options of that one drug? Respiratory quinolone. We'll label it as respiratory quinolone. And else? Doxycycline. Doxycycline is another agent. So these are the three options that you have. So augmentin you have started, and along to an atypical coverage you have added azithromycin. We can take that way, but the patient never had any atypical symptoms. So if you start augmentin alone, would have been sufficient enough. Maybe it has azithromycin has got an additional and an anti-inflammatory questionable property, but 3 days you can give azithromycin and stop. You can put her on a tablet also, which have equally efficacy itself, and you can stop. So problem is azithromycin, it can cause significant pain in your phlebitis and all those things. And never ever give azithromycin test dose. If you give an azithromycin test dose, the patient will have significant pain. So no need of intradermal testosterone or azithromycin. And allergy to azithromycin is very rarest of the rare report. Okay, so then what happened to this patient?
Patient.
What was her procalcitonin?
We haven't sent Procal.
Even never sent procal. Okay. So whether you need to send a procalcitonin, yes or no? I asked for procalcitonin. Whether you need to send procalcitonin, whom all you wanted to send a procalcitonin? What is the role of procalcitonin in ED?
If there is any doubt in if cardiac failure or infection goes in and bacterial to rule out fungal infection and bacterial infection, you can rule out by procal. Procal means significant of a bacterial infection.
Okay.
And so it is very high. You can know that patient is going to de-escalate the antibiotic.
That is what I wanted. That answer is most importantly. How the patient is progressing. For that reason, a single procal don't have any value. So that is the most important thing. When you are comparing two procalcitonin, it has got a significance. Whether you are going in the same treatment line, so then it will be useful. But single procal may be beneficial. We can predict very rarely. When procalcitonin came initially, when we are seeing quite stable patients sitting in front of me and we send a procal, it is above 100. So we all became panic and we thought of hiking up the antibiotics. So procalcitonin these days, what does it help? If it was above 100 and the patient we are treated, and after like 3 or 4 days, it will take a response time and it is still 100, then you are not going in the same, it is not adequate. If it has come down to less than 20 or something, you are going on the correct treatment line only. So hiking up the antibiotics might help escalation of antibiotic and also the de-escalation of antibiotic. By looking at a procalcitonin, don't jump and start amiropenam. So initially you are seeing a patient and the procalcitonin is above 100 and don't start amiropenam for that patient. So that is not required. So procalcitonin can, even in leptospirosis, we had seen a lot of patients with leptospirosis, procalcitonin being very, very high. So procalcitonin, single procalcitonin won't have much value. So that is and there is another marker, presepsin, that is the other one. Much before your CRP, much before your procalcitonin start elevation, you can use presepsin. What is the other thing that you can use in the ED, which you are doing for every patient?
Yeah.
No. No. Which you are doing for every patient? Neutrophil lymphocyte ratio. That is the other one you can do, is neutrophil lymphocyte ratio, and you can look at the ratio. If its ratio is very high, then you are thinking more in terms of an bacterial infection. So that is the other thing that you can do in the ED. So neutrophil lymphocyte ratio, presepsin, procalcitonin. So these are the markers. And CRP, yes, we say CRP, but it can, as you say, it can be elevated in other inflammatory condition also, even neutrophil lymphocyte ratio. But you have to take all together and with the clinical background of the patient. With this, you should come to a conclusion.